So very good evening to all of you. Respected Dr. Pareek sir, respected Dr. Girish Mathur sir, my dear friends, Dr. Puneet, Neeraj, G D, and Patidar, and Anil. A very good evening to all of you. And this is the right beginning for a new program of the case discussions and case-based discussions. We have already done two in the previous 2 months, and this is our third case. And today we will have another lightning topic to discuss. And before we go further, I request Dr. K K Pareek sir, our mentor, our godfather, our senior, and such a lovable man, and who has given all the inspiration to start these CMEs and scientific programs and various other programs to the physicians of the Rajasthan.
Thank you, dear.
Dr.
Thank you
Pareek
so
sir,
much.
please say a few words.
Thank you, dear. Good evening, everybody, friends. So, welcome to the third CME case-based discussions on diabetes. And I would like to compliment and congratulate to Dr. our dynamic president of Rajasthan RSSDI and Dr. Girish Mathur and President-elect Dr. Prakash Keswani, very energetic Secretary Dr. G D Ramchandani for this great initiative to disseminate knowledge to everyone in diabetes. I also welcome our speaker, Dr. Neeraj Lodha, very young and dynamic person, energetic young man, who will be speaking on this, starting this case-based discussion, and our panelists, Dr. Puneet Saxena, Dr. Anil Samaria, and Dr. P P Patidar, Endocrinologist. So it's really a good beginning, and I think this case-based discussions are always better than giving a lecture, although it takes a little involvement of many persons, but case discussions are better because you understand so nicely. As last time also, we just discussed everything about the type 1 diabetes. So it's really very good beginning and very good initiative taken by our president and Dr. Prakash Keswani. So let us have more and more programs like that to disseminate knowledge to our other clinician friends. And again, I welcome and I extend my sincere thanks to Dr. Prakash Keswani to making me a part of this very important discussion. Thank you so much, sir.
Thank you, sir. Thank you very much for your nice words. And as you told that these case-based discussions are really beneficial. And Dr. Girish Mathur, our president, RSSDI Rajasthan chapter, had inspired us to start this new kind of the sessions. And he has always been insisting for starting certain CMEs, certain certificate courses, and these case-based discussions. And I will request Dr. Girish Mathur sir to bless us with a few words.
Thank you, Prakashji. Good evening, friends. On behalf of RSSDI Rajasthan chapter, I extend a warm welcome to all of you on this third session of case-based discussion series in diabetes. At the outset, I extend my very sincere thanks and gratitude to our patron, Dr. K K Pareek sir, for his invaluable presence at this program. He is our source of inspiration and encouragement, and we are all fortunate to get his continued blessings and patronage. I also wish to thank Dr. Prakash Keswani, the project director, for his very sincere efforts in designing and executing this online program. It is entirely due to his credit that this program has been made a reality. I am also grateful to our dynamic secretary, Dr. G D Ramchandani, for all his valuable support and help. I extend a warm welcome to Dr. Neeraj Lodha, Senior Consultant and Diabetologist, Lodha Hospital, Pali, who will be discussing a case scenario of glycemic variability. And I'm sure with the presence of distinguished faculty, Dr. Puneet Saxena, Professor Medicine, SMS Medical College, Jaipur, Dr. Anil Samaria, Professor, General Medical College, Ajmer, and Dr. P P Patidar, Senior Endocrinologist, Jaipur. I hope we will have a very enlightened and meaningful discussion this evening on a very important aspect of diabetes management, glycemic variability. I again extend a very warm welcome to all of you and thank you for sparing your valuable time this evening. Thank you so much.
Thank you, sir. Thank you very much for your nice words. My efforts are very little, as you have given all the credit to me. It was just because of your inspiration that this program was started. Now we move towards the scientific program. For a long, we have been thinking that sugar should be controlled. Then came the concept of HbA1c. This gives you idea about the good glycemic control. Later on, it was found that it is not only the HbA1c, but many of the other parameters are equally important for good glycemic control, so we can avoid development of so many complications of the diabetes. And the concept of glycemic variability and 24-hour control and time in range, so many good things have come. And for this, to discuss this, we have a brilliant speaker with us. He will be giving the scenario of the various cases of diabetes, and Dr. Puneet Saxena, Dr. Anil Samaria, and Dr. P P Patidar. They will be the panelists to make it lively and to have a good discussion. And I invite Dr. Neeraj Lodha to please start your deliberation so we can move forward.
Thank you, sir. Thank you for nice introduction. I think now I am audible.
Yes,
audible,
yes.
Sir?
Yes, you are audible.
I
And
think these are the falsities of the technology. Sometime it may work or sometime it may not work.
40 हो गए ना साहब?
First of all, I want to thank Dr. Girish Mathur sir, Dr. K K Pareek sir, Dr. Keswani sir, Dr. Ramchandani sir for giving me this opportunity. And today we will discuss the CGM, the real world experience and glycemic variability. Second, next one. The content of this is a CGM brief introduction, then indication, then time in range, followed by case discussion and glucose variability. As I have put today a survey regarding the CGP experience of the different physicians, and I have put in this survey in the 3 groups, and as we are aware or we had seen in different groups that only the 5 to 10% of the doctors are using this CGM technology. So first we will discuss briefly regarding the CGM, then we will go to the cases. So the triangle of the diabetes management goal include the better manage of the overall glucose level, reducing the incidence of hypoglycemia and limits the glucose variability. So all these 3 vectors are needed for the better diabetes management. Next. Blood glucose monitoring technique like SMBG and HbA1c provide only a single point in time. HbA1c or the SMBG, it's just like a snapshot. And by the CGM or continuous glucose monitoring, we can know the whole picture, or we can know the whole picture of the sugar levels in the patient's blood. As we can see on the left side of the figure, only 4 readings are available with SMBG, while in the right side there is so much fluctuation in the sugar level from 300 to 200, 150. But by SMBG, we can know only the same level, and we feel that it is okay. But the case is not like that. There is so much fluctuation, high and low, and dips and hypo is there that we cannot know by the SMBG. Next one. The CGM is a system of continuously tracked glucose level, and it updates the reading every 1 to 15 minutes, and it includes 3 components: a display unit, a sensor, and transmitter. The sensor is in interstitial tissue. It is a small needle sort of thing, and it remains in the subcutaneous fatty tissue, and it detects the interstitial blood glucose level, and it sends the signal through the transmitter to the receiver. Next one. There are the two types of devices available. This is a Freestyle Libre and a personal, that is a professional CGM, and that personal CGM is also there. Next one. So the continuous glucose monitoring, right now we have a professional CGM and personal CGM. In professional CGM, we put the device on the patient arm or like other place, and the patient come back to us after 14 days, and we can analyze the things retrospectively. While in personal CGM, it is a patient own device, and the patient can check as many as time possible, like 10 times, 100 times, 50 times their sugar level. Next one. So in the CGM, we get the metrics of the time in range. We get the three metrics as shown here by the color bar. The yellow matrix is the time above range, the green matrix is the time within range, and the red matrix time below range. The ADA recommend the use of a standard report with time in range. The primary goal for effective and safe glucose control is to increase the total time in range and reducing the time below and time above the range. So we try to increase the sugar level within the range of 70 to 180 milligram. Next one. So CGM can lead to actionable insight beyond the SMBG. These are the advantages of CGM, and it has helped in the better management of over glucose level. Though the SMBG is by that we can know the sugar level, but it is a infrequent monitoring. And HbA1c, though the gold standard, but it doesn't show all the things what happened to the sugar level in the past. It gives the overall view of the sugar level, but not the fluctuations and glycemic variability. While the SMBG and may detect or may not detect the hypoglycemia, HbA1c can't detect the hypoglycemia, CGM can detect. Regarding the glucose variability, SMBG is not a good idea for that. Only the CGM can detect the glycemic variability. Next one. So these are the concept of the time in range. We try to keep the sugar within the time in range 70% of the time in CGM, and the time in range is between 70 to 180 milligram percent. The concept of 70% is come from the TIR of 70% is equal to the 7% of the HbA1c, and any fluctuation of 10% lead to the 0.5% either increase or reduction in the HbA1c level. Or for the time below the range, we try to, there are the 5 categories. It is between the 70 to 180, that is the TIR time in range, and from 70 to 54 time below range, it should be below 4% or less than 58 minutes, and time below 54%, it should be less than 14 minutes or less than 1%. And for the time above range, it should be less than 6 hours, i.e. between the 180 to 250 milligram, and above the 250 milligram, it should be only between 1 hour or 12 minutes. Next one. So these are the indication for CGM. It is indicated for all type 1 to diabetic patients, and the type 2 patient that require the intensive insulin therapy. Those are on the multi-dose insulin or the continuous subcutaneous pump therapy. Or type 2 patient is having a history of severe hypoglycemia or repeated incidence of hypoglycemia, or there may be incidence of, they are indicated in asymptomatic hypoglycemic or nocturnal hypoglycemic patient. Those patients who are suffering from the refractory hypoglycemia, and especially the morning hypoglycemia, hyperglycemia. And those patients, those are having the large glucose excursion. It is also indicated in gestational diabetes and any diabetes in pregnancy. It helps in the understand the glucose fluctuation caused by the factors such as exercise, meal, stress, hypoglycemic treatment. These factors, we cannot know how it influences the sugar level by the HbA1c or SMBG. Next one. So I have already discussed, there are the two kinds of CGM, professional and personal. Professional is owned by the clinician. It is an intermittent use. It is a and a retrospective evaluation can be done. While in the personal CGM, it is a real-time data can be analyzed by the patient, and patient can do the different kind of intervention while checking his own sugar. Next one. So this is our first case. This is a patient named Apurva. She is suffering from the type 1 diabetes since 2013. Presently, she is doing the BE in third year. It's engineering college in Pali. She has a history of ketoacidosis in 5 to 6 times in last 10 years. Next one. Her treatment include the 4 times insulin dose, 25 units regular insulin before breakfast, 20 units before lunch, and 18 units before dinner. And this insulin galargen at 35 units at bedtime. Her HbA1c was never under control, except we have done in June. It was in June 22. It was 6.9. Otherwise, it was always about 10 or 10, around 10. Next one. And this is the SMBG chart that she had done at her home. And her sugar was never appears to be controlled, except one finding of fasting 90. Always it was about 120, 30 or around the 300. Next one. Now the HbA1c of 6.9 and with such HbA1c 6.9 with such high blood sugar SMBG monitoring, patients were happy, parents were happy, but doctor was confused. I was confused how it can be happen with such high reading. We have suspicion on report. Report was repeated from other lab with same result. Next. So we have done the CGP. Now we can see the CGP. These are the ambulatory glucose profile chart of this patient. And this is the complete chart of the 14 days. And as we can see in the upper panel, there is a median or mean glucose level of that time from 0 to 2, 2 to 4, like that. And as we can see the 2 red marks, 58 and 63. So there is a hypoglycemia overall from last 14 days at that time. But there is a high sugar level in the daytime, like between 12 to 14 and 18 to this 6 to 8 hours. It's around 195, 189. Next slide. So how we interpreted this report? This is the graph that we have seen in the last diagram. This includes the 3 parameters. The dark line in the middle is the median line, and the dark blue para is an interquartile range, and the light blue is an interdecile range. Median line shows that mean sugar 50% is above this line and 50% is below this line. And this interquartile range from the 25% to 75% range of the sugar at median level. So 50% of the, I think other people mute. So 50% of this interquartile range from 25 to 75% is above the median line and 50% is the below the median line. And interdecile range is connect from the 5% to 95%. So interquartile range, basically the wide range indicates that the intervention requires in the treatment of the patient, while the wide interdecile range, it shows the intervention needed in the patient's lifestyle. Ideally, all this should be between the 70 to 180, and the broad line, it should not be like that. It should have a small line that we will discuss in next slide. Next one. This is the assessment of this graph of AGP. As we can see in the first line, there is a very small snake, or we can see it, say it. There is a median line and a small dark blue on a small blue line. It shows the means the low variability in the interdecile range and interquartile range, and a low glucose variability and comparable with glucose variability in a metabolically healthy individual. While the wide interquartile range show the low variability in the high variability in the interquartile range, and treatment adjustment is required. While in the high variability in the interquartile range means the adjustment of the lifestyle adjustment, exercise intervention, or alcohol intervention is required. And but if it is a both wide, both IDR and IQ are wide, then the intervention in treatment and intervention in patient's daily lifestyle is required. Next. These are the AGP profile of the every day. We can't analyze because there is so much mixing in these things. Next slide. And these are the different parameters that are available in the CGM report. Next slide. These are in this picture, we can see so many red dots on the left side of the picture. And these dots represent the hypoglycemic event of the patient. And these are the by these dots, or these are the sugar levels that are measured by the CGP system, the whole picture is analyzed. Next one. And this is the daily glucose summary chart of the patient. As we can see, the red line, yellow line, and the blue line. Red line represents the hypoglycemic event, and yellow line represents this color represents the hyperglycemic event. On the right side, there is an interpretation of the patient report. That is the mean glucose, then the time between the range, time below the range, and time above the range. And it comes in the percentage wise. So as we can see, the patient has a quite high incidence of hypoglycemia and hyperglycemia. As we can see in the 8 June reading, there is a 30% time patient only on the time in range, while in 24% time it is a hypoglycemia and 46% hyperglycemia. That means the patient is having the normal HbA1c, but her sugar was not on right track. Either she is having a hypo episode or hyperglycemic episode, and the time in range or the normal level of the sugar is very low on time, only 31% of time. Next. This is the remaining chart of the 14 days. So there overall the sugar level or mean sugar level was 138 for last 14 days, but the time in range is only 31%. That ideally should be around 70%. And hypoglycemia should be less than 4%, but it is quite high, 27%, and hyperglycemic incidence is of 42%. So the HbA1c is okay, it is about 6.9, but the patient is not on right track, or her sugar level was not right. She is having so much fluctuation in her sugar level, as we can see these figures. There's a early morning quite high, low sugar from 60 to 70 mg%, and in the daytime her sugar was quite high. It's going above 300. Next slide. So our treatment we has changed. This is our prescription. As we can see, there is a 3-time insulin and 9-time basal of high dose. Next. So we have changed the treatment. Basalog is shifted to in the 20 unit in the morning, and the regular insulin dosage is also adjusted according to her meal. And she was advised to do some exercise post meal in the early morning time, this late evening time, and by the intervention of CGM, we can able to detect the this hypoglycemia at night. That was patient was not aware, and the doctor was also not aware, and the CGM helps in the changing in the treatment plan. Next one. So what is the CGM consideration in pediatric patients? It is recommended for the patient with history of severe hypoglycemia or hypoglycemic unawareness, and in assist in the correction of the sugar level. It is also indicated in those patients of the type 1 diabetes, those are having the this HbA1c below 7%, because the HbA1c below 7% patient may have the episodes of hypoglycemic unawareness that is not detected by the HbA1c level. Next slide. This is another case of a type 2 DM patient. This is Mr. Rajan Bell. He is having a diabetes since last 15 years, and is suffering from the coronary artery disease since 2015. His coronary artery angiography shows the 70 to 80% luminal narrowing in the mid segment of the LAD. And he was stable on the medical treatment from last 8 years, and he refused for the stenting. From when he came to me, he has a 3 to 4 episodes.
Before going for the second case, can we discuss for some time what was the indication for going for this CGM in that particular young patient? What inspired you to go for this? Were there any specific complaints?
Of first patient or this patient, sir?
First patient.
So the problem is with that her HbA1c was 6.9 and her SMBG was quite high, and it was recommended that those type 1 patient having the HbA1c below 7, you should go for the CGM. So SMBG recording and her HbA1c is not matching. So for that we have done.
You thought that there must be something bad.
Yes.
HbA1c was good, but SMBG was not good, but HbA1c was good.
Yeah.
Yeah. May I ask something?
Yes,
Yes.
yes.
Yeah,
Dr.
yeah,
Patil.
it was a very good case. In day-to-day practice, we see many patients come with the very high dose requirement in type 1 diabetes. We all know that in type 1 diabetes, insulin resistance is not there. So requirement of the daily dose of insulin in type 1 diabetes should not be more than 1 unit per kilogram per day in most of the cases, until unless patient is very obese, because most of the type 1 diabetic patients are lean. So in this case, the daily requirement of insulin was 98 unit per day, which provoked our thought process that why he was on 98 unit of insulin. So this was, I think, this was the factor which was the reason for CGM installation, because the requirement is must not be very high, and HbA1c was controlled, so he must be having hypoglycemia. And one more thing in that case, we can interpret the individual line as in your case, Neeraj sir, you can interpret it individual line of 14-day chart. You can ask your patient that note down the dietary pattern, exercise pattern for the 14 days whenever you install CGM, so that you can interpret the daily exercise and diet with the up and downs of the sugar levels. So that may be,
That is right, sir.
yeah,
We
that
have
may be
done
the
this
training
with
part.
patient. Her sugar is usually go high in her college time, and
Yes.
she confessed that she usually eat the food like fast food and mirchi vada kofta and like that
Yes,
food in
yes,
her
yes.
canteen, and that may be the reason of her high sugar in the daytime also. क्योंकि
Wonderful.
वहाँ बच्चे को भी भूख लगती खा लेते, कैंटीन में कोई कहने वाला नहीं था, आइसक्रीम भी खा लेते बच्चे,
Yes.
because there is no surveillance by the parents.
Yes.
घर पे तो that may be reason. और एक और सा reason हो सकता है, patient don't move for 6 hours or so, they remain in the class for that time, so there is a very less movement, and that may be the reason for this high sugar at that morning, this
Yes.
afternoon time especially. Post meal they usually sit in the class and no movement or no physical activity is there.
Yeah. So we can train the patient that when you have to you have to eat something, the gap between two meal, what is the appropriate gap, time gap. And one more thing, you can see weekdays and weekend differentiation of the chart, because in the average 14-day chart, in your case, dip was between 2 a.m. to 4 a.m. But if you want to compare Saturday, weekend and weekday chart line, you can differentiate the lifestyle also. You can educate the patients.
Sir, in this one slide, this one day the patient is having the more or less normal sugar, because it was she was at no you go up. अगला चला ना slide, next
हाँ, back.
this
Yes.
इसके पहले वाला. हाँ, on sir 9th, I think
Yes.
that was her holiday, 9th, 10th, 11th, so more or less her
Yes.
sugar was quite good.
Hmm.
उस टाइम घर पे रही तो वही खाना खाया जो मिला, और
Perfect.
स्कूल में आया कि वहाँ कॉलेज जाते ही सब गड़बड़ हो गया.
Yes.
Next slide.
Thank you, sir. So we can ask patient to note down the 14
Ideally,
days.
sir, this.
Yes,
Yes,
sir.
you tell.
We also record, sir. We
Yes,
also
sorry.
record the diet schedule of the patient. What he is eating, make a diet chart also, so we can reduce the calorie cut down. In spite of increasing the dose every time, it will reduce the hypoglycemia. Next time, if a patient is not taking much of calories, patient might go into hypoglycemia. So diet recommended, especially in children. Parents are also educated regarding this. How much calorie patient should consume, what calories should provide, and what is the content of the diet, or how much amount of glycemic index of the food should be explained to the patient. My suggestion is also that you can also manipulate like this. Or CGMS gives a very good result in the glycemic variability.
Next
Yes.
slide.
Sir, Dr. Shivendu here. Can I
Good evening,
make
Dr.
one
Shivendu.
comment?
Yes,
Sir,
Dr.
we
Yeah.
can
Shivendu,
have
good
discussion
evening.
after the test
There is a
because
very good paper published by no other than Dr. Anil Bhansali from PGI Chandigarh, that the patient who does not have, remains idle, at least make them educate or compel them to walk for 5 minutes even after each meal. Their glycemic control is to a great extent improves. The new paper by Dr. Anil Bhansali from PGI Chandigarh. Does this thing have, can be applied to this gentleman?
sir, we have case also.
Yeah, definitely.
Sir, we have case of like that also that we will discuss. Next slide, please.
Yes.
Next.
So we can move
Ajay,
further.
next slide
Case
लगाओ.
now.
Yes, sir. Second case, please.
Next, हाँ,
Okay.
बस ये वाला, इसके पहले वाला.
Thank you.
अजय,
Okay.
इसके पहले, हाँ.
Friends,
So,
Dr. Neeraj,
Mr. Rajan, well,
Girish,
I
how
think-
are you? Fine.
Dr. Neeraj, friends, let me welcome our friend Dr. Shivendu, who is from Kolkata, as a past Vice President API. And we are fortunate that he is on board attending this webinar. Thank you so much, Shivendu.
Thank you, sir. Thank you. Welcome, sir.
Welcome, Dr. Shivendu.
So, Mr. Rajan Bell is having a history of diabetes from last 15 years and coronary artery disease from 2015. And at that time in December, his coronary artery showed the 70 to 80% luminal narrowing in mid segment of 5 mm. And he was stable for around 8 years on the medical treatment. But when he came to me, he has a 3-4 episode of early morning ghabrat, shortness of breath, and chest discomfort. And he consulted the cardiologist on echo. His HbA1c was LVF was 60%, and coronary angiogram showed the same picture of 70 to 80% of mid-segment narrowing. And the cardiologist advised him for the stenting, but he refused for the stenting. In the 2015, he refused for the stenting, and in 2022, he also refused for the stenting. And so the cardiologist prescribed him all the medical treatment, but he don't get any relief. Next slide. This is the coronary artery angiography imaging. As we can see, there is a small soft plaque with short segment 5 mm, 70 to 80% luminal narrowing. It is of 2015. Next one. This is of the 2022 coronary angio report. That also shows the approximately 5 mm 80% narrowing in the LED. Next slide. So we have done the CGM in that patient. As we can see, between the 2 AM to 4 AM, there is a quite dip in the sugar level. It's going to below 60, around 50 or 60 milligram. Otherwise, the sugar was more or less within range. As we can see in this picture, both interquartile and interdecile figure are quite narrow. The median line is quite bright. So the early morning hypoglycemia is there. Next one. So it is a daily glucose summary. On the very first day, we were able to detect his early morning hypoglycemia. So nighttime dose of this OHA was stopped on the next day. And from the next day onward, the early morning hypoglycemia was literally vanished. Next slide. So as we can see on all the picture, there are the very few episodes of early morning hyperglycemia after stopping the nighttime OHA. And for this patient, it was a perfect normal thing, around 70% time in range and only 9% time above range. So next slide. So there was a severe episode of post-midnight early morning hypoglycemia. Treatment was reviewed and late night, this evening time hypoglycemic agent was stopped and insulin dose was also reduced. And patient is a cyclist, and now his patient is stable from last 6 to 7 months and doing regular cycling around 35 to 50 kilometer daily. Next. It is his prescription. He was on injection Tuesday of 15 unit HS and tablet Jibdu twice a day, and he was also on the Voglibos. Next. So the treatment was reviewed, and after that he is having no problem, and he regularly comes to me without any problem of cardiac illness or any ghabrat and like. And recently he done 120 kilometer cycling in 3 hours and get some batch of the cyclists. They are doing some competition like sort of thing. Next one. This is our third case, TPK, 54 years old, 7 years of diabetes. HbA1c was good, 6.8. The treatment is of 500 milligram metformin, glimepiride 1 milligram once a day, but patient was not well. He is having complaint of weakness, tiredness, irritability, not feeling well, not having the energy. CGM was done. Next. As we can see, there is a quite variation in the sugar level. In the evening, it was in the night, it was okay, but there is a high surge in the early morning. It usually the mean sugar is 204. There is a surge in the level of the post lunch and post dinner. As we can see, the 25 to 75% interdecile range or light blue, this dark blue parameter is quite high, while the light blue parameter that is interquarantine range is very short or very small. So the problem is with probably with the treatment of the patient. So the HbA1c was okay. And as we can see in the right upper quadrant, there was estimated HbA1c. In this CGM, the machine automatically estimate the HbA1c on the 14 days reading, and patient daily average was 141. But HbA1c both estimated and the monitor, this measured HbA1c was within normal range, but patient was not well. Probably the reason was the this hyperglycemia or post-meal PPG, high PPG was the reason. Next one. So these are the chart of the patient. As we can see, so many yellow colored spots post-meal in the morning time, in the post-lunch time and post-dinner time. So between this, we have reviewed his treatment. Next one. And after the change of the treatment, there was a quite decrease in this yellow dots or yellow spots or post-meal spikes. Next. Once again, previous one. So in that one, we can see the overall the sugar was 141, but TIR is only 53%, as we can see in the last point, and the time above range is 44%. So with the HbA1c around 6.5 or 6.9, all are happy. It's okay. And patient is also feeling not good. And doctor was happy and relatives were happy. HbA1c to sahi hai, but patient kyun nahi theek ho raha hai? Probably the glycemic variability was the reason. And the TIR is only 53%. Next one. So the time in range is only 53%. Ideally, it should be 70%. And it shows that there is a high PPG. So the voglibos was added with all the 3 meals. Glimepiride was stopped and metformin was given twice daily. And the important thing, we have also the adjustment of diet. Patient usually take the high carbohydrate diet in the morning. Pohe wohe zyada khata tha, idli khata tha. So we have stopped all the things and we have started some healthy protein-rich diet. Next one. And now we can see this is the after 3 months of the patient change of treatment and change of diet. It was a perfectly normal. As we can see, estimated HbA1c 5.1, no spike. All the sugar range are within the normal range. This is the beauty of CGM. And there's I think most of the Indian type 2 diabetic patients are this kind of patients. We need to teach them their food habit. We have to change their food. We have to change their exercise habit, and especially the carbohydrate should be curtailed. And all patients ideally don't need the sulfonylurea. Most important is the diet adjustment and the exercise regime that can help the most of the patient. And I think as Dr. Shubhendu has also told, the post-meal steps or a few minutes walk can also help in controlling the sugar of the most of the type 2 diabetic patient. Next one. So these are the recommended glycemic target for the type 2 diabetic patient. Those who are the young diabetic type 2 patient, those who are the perfectly normal, the HbA1c should be below 7%. TIR 70 to 81 milligram, it should be above 70%. And under 70%, it should be below 4%. And under 54, it should be below 1%. The last figure, glucose variability, we will discuss in the last. Ideally, it should be below 36%. Or those patient, type 2 patient, those who are of the over age, or that's above 70 years, or those who are having the comorbidity, this criteria has been relaxed. HbA1c should be less than 8%, and TIR should be above 50%, and hypoglycemic incidence should be reduced to 1%. Next one. This is the recommendation of the South Indian people of the frequency of CGM. And this is recommended by our own Jyoti sir and this Dr. Bansi Sabu and all. And those who are patient having the TIR more than 90% of time, it is recommended to do CGM in every 6 months. और जिनका भी TIR 70% से और 70% से ज़्यादा है, they should repeat the CGM in every 3 months. Or those patient who are having the less around 50% of TR, the CGM should be repeated every 2 months. Next. This is our last case. This is a Neetu, 28 years old patient suffering from type 1 diabetes. She has a history of fetal loss during first delivery, and she was quite motivated in her second delivery because of the peer pressure and pressure from her in-laws that there should be one healthy child. And she was admitted at our hospital for the gynec reason, and we have done the CGM on her. And luckily, it was she was delivered healthy baby. The next one. As we can see, there was a quite good control in the patient's this daily pattern, and most of the figures are within the normal in 80 to 140. But in that, we can see that dark line is quite small, and it is quite confined to the median. But interdecile, the light blue figure is going quite high above this. Next one. As we can see, there is a daily graph pattern of the patient, and we can see 2-3 lines are quite high. Otherwise, most of the lines are within the normal range. Next one. Next. As we can see, so many red spots. Otherwise, it is a hypoglycemic events in a normal patient, but it is required in a pregnant patient. And this is not an incidence of hypoglycemia. It's a sugar level below the 80, between the 80 to 70 to 80 milligram that is reside in every pregnant patients. Next one. This is her daily glucose summary. So lot of red lines, but this is the normal for the pregnant lady. As we can see, the average sugar level between 105, 77, 69. So it was a perfectly normal, except for one day, 152. Next one. So all the 14 days, overall the 90% of time, this overall mean sugar is a 90 milligram. And though it was showing that 61% of time patient has a hypoglycemia, but it is normal for the pregnant female. Next one. So CGM in pregnancy. CGM advantages in glucose monitoring. It detects within day glucose variation mixed by the HbA1c. Mixed by the HbA1c and SMBG. SMBG अपन कितनी बार करेंगे? 4 बार, 5 बार. But by CGM, we can do 100 times by the personal CGM, or by professional CGM, we can detect the every 15 minutes sugar level. That was not possible with the SMBG. There are some falsies also. CGM values are slightly higher in women with diabetes compared to those without. And difference in the PPG level ultimately leads to the delivery mode, infant birth weight, and diabetes-related complications. So there is a strict criteria in the pregnant woman, especially for the PPG sugar. So application of CGM in pregnancy elucidates the glucose variability and glycemic in pregnancy with or without diabetes. So the CGM is quite helpful in the pregnant ladies, and it helps in the controlling the glycemic variability and helps in the detecting the glycemic patterns. Next. These are the criteria, as we all know. These are the criteria glycemic targets for the gestational diabetes, pre-existing diabetes, and diabetes with a significant hypoglycemic episode. There is nothing new in this. Next one. So CGM is a safe and accurate in pregnancy. there is a so much beneficial. It is a successful, safe, and accurate. It is better than SMBG in detecting the high postprandial glucose level and effective in identifying the nocturnal hypoglycemia. And definitely, it is a potentially superior over the SMBG patient. Ideally, all the pregnant patients with diabetes should have this personal CGM or patient hope CGM to detect the sugar levels and to control the sugar level. Because the SMBG is probably only a snapshot while the CGM is a complete picture. Next one. So these are the different criteria and different sort of patient. In type 1 and type 2, we should try to remain in 70% of time in the time in range. In older patient, it is a little bit relaxed criteria to 50%. And in pregnancy with type 1, it is above 70%. And with gestational diabetes, it is above 90%. So it is the ideal thing, and we should try in every patient that we should try to keep the sugar within range in most of the time. Next one. Now the glycemic variability. It is the swings in the blood glucose levels or blood glucose oscillation that occur throughout the day. It includes the hypoglycemic grade and postprandial increases as well as blood glucose fluctuation that occur same time on different days. We all like swings. अपन सबको swings पसंद है, but swings in blood glucose should not be there. Though there is a circadian rhythm or a variation in the every hormone, every parameter of the in the blood of the every human being, and there is a variability in the sugar level of the normal persons only also, but it is only up to around 20 to 30 mg%. But in diabetic patient, there is a marked glycemic variability. The broad definition of GV considered the intraday glycemic excursion, including episode of hyper and hypoglycemia. Next one. Now the pathophysiology, micro and macrovascular complication of diabetes attributes to the not only to the hyperglycemia but also to dysglycemia. Dysglycemia means both peaks and nadir. Excessive protein glycation, end products, and activation of oxidative stress cause the vascular complications. Intermittent high blood glucose exposure or high PPG leads to oxidative stress and atherogenic action, and it also involves the insulin sensitivity and postprandial increase in the serum lipid levels. In vitro study showed the glycemic fluctuation was associated with endothelial dysfunctions. So the glycemic variability and high and low levels are quite important in the diabetic pathophysiology and the complication, especially the macrovascular complication of the diabetes. Next. There is a significant association between the high glycemic variability and increase in incidence of hypoglycemia. And hypoglycemia is a very dangerous factor, as we have been seen on the various trials like ACCORD trial and like that. And it triggers the inflammation by inducing the release of the inflammatory cytokines. It induces the platelet and neutrophil activation, and the sympathorenal activation during the hypoglycemia increases the adrenaline secretion, leading to arrhythmias and increase in cardiac workload. Next one. So these are the various glycemic variability indices that can be detected by the serum, from the serum and by the continuous glucose monitoring. Among them is the MACE is important. That is the mean amplitude of glucose excursion. In that, high and low sugar level of the different times and different days are taken, and by that the standard deviation is derived and the MACE is taken. But nowadays other parameters are more into consideration that we will discuss in next slide. By serum, we also can detect this glycemic variability by the glycated hemoglobin and by the ratio of the glycated albumin, and by the ratio of the glycated albumin and glycosylated hemoglobin. And CGM is also divide of the most of the unpredictable results from the HbA1c also, like in hemolytic patient with incidence of hemolysis and other patients like this nephropathy patients. Next one. So these are the new parameters, mean glucose that can be derived from the CGM. The mean glucose that we have already discussed, it is the mean value of glucose measurement recorded by the system during the period of analysis. And important is the GMI, glucose management indicator. It is now replacing the estimated HbA1c as we have discussed in our this patient's discussion. And GMI is a new parameter that assesses the glycemic control based on the mean glucose level. And as we can see, it can be calculated by 3.31 into 0.0239 into mean glucose concentration. More or less, it is equal to the estimated and the measured HbA1c. But if there is some discrepancy, then we should think about the relevant this report of the HbA1c, whether it is some problem or some patient is suffering from other problem that may be interfering with the HbA1c. Now the glucose variability, it is assessed by the coefficient of variation and glucose measured during the analysis period. The recommended CV value, it should be less than 36%, and higher the variability is associated with high risk of hypoglycemia. There is a mathematical calculation. Next slide. So the percentage of coefficient is a standardized measure that assesses the magnitude of glucose variability. The standard deviation is the mean of glycemic CGM data, and it is the simplest tool for the assessment of glycemic variability. The ST can be detected by there is some little bit complicated formula, and by putting that formula in different sugar levels, we can derive the standard deviation, and by standard deviation we can calculate the percentage of coefficient. Percentage of coefficient variation is the standard deviation by mean glucose into 100, and the glucose variability takes into account the intraday glycemic excursion, including episodes of hyper and hypoglycemia, and is calculated by the, as we have seen in the previous slide, by the GMI. And GMI we can see or it can be calculated in percentage or in millimole per mole. So the percentage coefficient, it should be below 36%. We should try to keep it below 36% in the diabetic patient, and in the non-diabetic it is usually around the 20-25%. Next one. So to conclude, CGM in type 1 and diabetes is in type 1. Type 1, it is a well-established improved glycemic control and reduces hypoglycemia. Type 2 management is a heterogeneous and include the lifestyle modification and oral medication and intensive insulin therapy. CGM helps in type 2 patient management, enabling individual to make timely adjustment of medication, diet, and lifestyle. That is not possible with HbA1c. Next one. So the CGM helps in the type 2 diabetic patient, those who are on multi-dose insulin or insulin pump therapy, or it is also recommended in type 1 or type 2 patient, both on MDI and insulin pump therapy. All individuals with problematic hypoglycemia, in pregnant women, whether they are type 1, type 2, or a GDM. Next one. So time in range metrics provide more actionable information than HbA1c alone. The time in range includes 3 key measurements, as we have already discussed: time above, time below, and time in target range. And it recommends the use of a standard report with time in range. Next. CGM creates a fuller profile of the glycemic data and trends compared to the limited information gained from the HbA1c as it relates to the glycemic variability. And studies show that CGM improves the glycemic control and reduces the HbA1c level and decreases the hyper and hypoglycemic episodes. Next one. Next. I take this opportunity on the behalf of organizing committee of Raj RSSDI and executive committee of Rajasthan RSSDI to invite all of you in this Hara Bhara Ranakpur. In March, we are organizing the Raj RSSDI in the March with the blessings of Pareek sir and Girish Mathur sir. So all you are invited. We will have a good scientific feast and try to welcome you with our Marwari tradition. Padai party, sab kuch karenge, trekking वगैरह. And there is so much places to visit here. We have 3 leopard sanctuary within a 1 hour distance from the Ranakpur, in Desuri, in Javai Dam, and in Kumbhalgarh. There is so many trekking place. There is one very ancient temple of Shivji Parasram Mahadev, and there is a trekking of around 5 kilometers. And from there we can another 7-8 kilometer trekking we can reach to the Kumbhalgarh. And in this picture, the famous Jain temple is shown in the Ranakpur. It is quite old temple. So on the behalf of organizing secretary and our organizing committee and Rajasthan RSSDI Executive Committee, I invite all you to Ranakpur. Thank you. Next. And again, thanks to Pareek sir and Girish Mathur sir for giving the opportunity.
Yeah, it was a wonderful talk, and all the cases were very well explanatory about the uses of CGM. And I would like to add few things. We can use CGM in pancreatic diabetes. That is very common nowadays after the damage of pancreas either by the FCPD or by the alcoholic pancreatitis. So in that case, pancreatic diabetes is very level type of diabetes where hypo and hyperglycemia are very common, and the use of 2 unit excessive or 2 unit less unit of insulin can cause hyper or hypoglycemia in pancreatic diabetes. Your second case was very well explanatory that how patients develop symptoms in early morning can lead to a angioplasty or other procedures. So it was a learning case. We should explain every patient with diabetes that you should do first your glucose testing before going for the before measuring your blood pressure and going for ECG. So it was a very good case.
Thank you, Dr. Neeraj. The cases were really good, and the implications and about the glycemic variability and avoiding glycemic variability and preventing so many complications, including ischemic heart disease or can be helpful in hypoglycemia, unawareness, and so many things. In which kind of the cases usually you recommend, Dr. Neeraj, this glycemic CGM?
Sir, ideally it should be prescribed in every type 1 patient. And in type 2 patient, as we have already discussed, those patients who was on the multi-dose insulin, those who are suffering from the hypoglycemic unawareness, and those who are having the high hyperglycemia in the early morning. These are the ideal case for the recommendation. Or ideally nowadays it should be recommended for the every type 2 patient, those who are not on good control or most of his symptoms cannot be explained by the other disease and the patient is not doing well.
Neeraj, let me congratulate you for a beautiful presentation and a good case discussion. I perfectly remember when I passed out my MD exam. So we were doing 5 Benedict tests. Urine को उसको गरम करो and
your voice is not.
Your voice is breaking.
That time when
No.
my voice is okay. Anyway, yeah. So the point is this: when we finished RMD and then blood sugar came, it was a surprise to us. Can it be possible like this? And then we used to, over a period of time, used to once in a week or once, twice in a week, we organized many of the camps from 82 to almost 90. And there was a lot of rush. There was choti si machine aapka sugar batati hai. Then time came for SMBG. And let me tell you, friends, United States doing SMBG or glucose monitoring is absolutely obsolete. It has been ensured that all CGMs, most of the friends, they all carry CGM. So CGM is in fact today's time, number one. Looking in our scenario with the price factor, we should be little scary patients who do not follow the guidelines to the patients or who are not good at doing with the diet. And they often just do not believe in the doctors and often keep on eating and not eating and doing a lot of fasting or giant fasting, giving a lot of problems. So in such a scenario, CGM is a good answer. But let me tell you, CGM again has an ethnicity variation. If you see a CGM putting in a Caucasian population and doing an Indian population, postprandial variation, insulinemic effect, glucose effect, they are different than the people of a Caucasian. Many of the reasons are we are primarily pro-inflammatory, more diabetogenic, more atherogenic, and with high inflammation molecule. At the same time, our diet pattern is not very good. Our cooking media is not good. The kitchen is always at the fault, giving a high glycemic variability. So GB variability does have high GB variability, has a high incidence of morbidity and mortality, even high incidence of septicemia and then influenza deaths. And if you see overall severe risk factors and then diabetic foot, high incidence of microvascular, macrovascular complex are always associated with the GB variability. But anyway, your presentation is very good, but certain observations. One observation, you said that the post-meal you should exercise. Absolutely no. You can do a little walk, you can just go along, but don't exercise.
Sir, I have told that
Number two,
the
in
few
second
steps
case,
I have
that
not taken
there
the-
was you were putting in the basal 20 units and while the rapid acting insulin 25, 80 and 12. Extreme, twice the dose in the morning hours and evening hours are probably not a good diet pattern. So primarily, if you want to see this GB variability and or what we can call as exertions, the primarily it is a doctor's fault or the patient fault. The doctor's fault that they fail to understand the situation, and the patient fault is that they keep on eating a big meal while the message should be small, frequent meals, which could be at 3-4 hours, where the low carbohydrate diet can give you a better answer. It is a 99% of the diet chart is not good, right? So we should always stress, we should always counsel the patient. And I always ask my patient to eat an apple or some fruit 30 minutes before taking a meal. And that has helped me a lot doing a good. But anyway, my all congratulations. And I personally impressed by your presentation at the Kanakpur also. I do agree. And I'll request my fellows also to be there with you at RSSDI, giving the highest ever attendance in Kanakpur. Beautiful. Congratulations and good night.
Thank you, Dr. Pradyuman Sharma, for your nice inputs. Any other? Dr. Anil, Dr. Puneet, will you like to give your inputs? Dr. G D Ramchandani, you also good.
Very nice explanation by the doctor. Sir, very nice explanation by the Dr. Neeraj Lodha, sir. And there is definitely there in the coming year, we need the CGMS in each and every type 1 diabetes patients. So we keep watch over these kind of patients, especially in children's, because of cost is a matter in India. You know that. But in our setup, the government is providing the free cost for CGMS instrument as well as an insulin pump also. So we can use these kind of pump and insulin pumps and the CGMS in poor patients, so we can help them. So nowadays, the CGMS instrument is a very good requirement for the type 1 diabetes, or also for the bile diabetes, in pancreatic diabetes, because these patients require frequency. So we keep the glycemic target within the range. So prevent the micro and macrovascular complication, because as the Dept trial also said that there is a microcardiovascular mortality. So need close watch over the glycemic excursion and hypoglycemic events by the CGMS. Very nice presentation by the Dr. Neeraj Lodha, sir. Thank you.
Thank you.
Dr. GD, will you like to say something? Your inputs?
No,
We have
everybody
a
is
big number of
discussing.
type 1 diabetic patients. I think they are many of the time need CGM.
Definitely, sir. First of all, I would like to congratulate Dr. Neeraj for the wonderful presentation. And not only type 1 cases, but all 4 cases were very well discussed. And this shows the use of CGM. I think it's still underused. Probably we are also not aware. We doctors are also, when patient are not mentally prepared. Then third time they will ask, and they used to purchase from, and they used to come bring. This is what I have seen in type 1 patients. I think its cost is also important, but it's not very expensive. In fact, if we are doing blood sugar twice in a day and for 14 days, and on one hand, on other hand, you are using the CGM, the pain factor and control factor is very nice with CGM. And once they are using, affordable patient they are regularly using in our setup. They are purchasing from some of the online, and they are using themselves nowadays. So definitely I would like to congratulate all the team. And thanks once again for Neeraj for giving this wonderful message also. And we have our senior API member, Dr. Shivandu, also here. And I also request him to their experience, their few words in about this RSDI case-based discussion program of Rajasthan chapter, sir. Dr. Shivandu, sir.
Dr. Shivandu, are you online?
Sir, I am online. Can you hear
Yeah.
me?
Yes, sir. Yes, sir. We still remember
Yes.
your talk on
Excellent
obesity.
program,
Really very
Dr.
good.
Keswani. Your team of Raj RSSDI. Special congratulations to Dr. Lodha for his excellent deliberation. And now in our part of this country, which is a coastal region of India, we found lots of patients of thalassemia, where we never rely on the HbA1c, which is very, very, what I should say, is impractical to go on HbA1c at least. And here CGM is very important, and particularly what Dr. Lodha has said about pregnancy, it's a very beautiful. The pregnancy without CGM, pregnancy outcome may be very fatal sometimes. It is better to go with this CGM with all pregnancy patients. Now, I also congratulate for two things in all Rajasthan, curriculum of webinar. It is so fast, so simple to enter your program that probably no other webinar in the country can compare with. It's a great, congratulations should go to Rajasthan's, RSSDI and all other programs. So thank you everyone, the team Rajasthan, for presenting such a very good webinar in this day. Thank you very much, sir.
Thank you, sir, for your nice compliment for our team Rajasthan. And we still remember your talk on obesity. Everyone was everyone liked it. really slides were really very good. Impressive.
Yes, sir. Thank you, sir. Thank you.
So I think with this we can conclude today's session. And again in the next month, on the second Thursday, we will be going for another case discussion on the diabetes. At the last, I will like to thank again Dr. Neeraj Lodha for a nice presentation, Dr. Anil Samaria, Dr. P P Patidar, and Dr. Puneet for being panelists, and Dr. Shivandu, our guest, and always a source of inspiration. You have a good interest for the academics also. And Dr. Pareek sir, Dr. Girish Mathur sir, and Dr. G D Ramchandani is always inspiring and very active and hardworking. So in the last, I will thank you all and
thank you,
for
sir.
participation. Bye bye. We will meet the next.
Bye bye, sir.